Dear Pure Urology viewers, good evening, one and all. Today we are talking on a focused case-based surgical technique, that is a large prostate enucleation of the prostate with holmium laser by Dr. Tanush Pal Bhatia. Previously has given talk, even then for the newcomers, I will introduce Dr. Tanush Pal Bhatia, who is focusing on all endourology, more so on enucleation of the prostate. So to start with, so today topic is 350 grams prostate, how I did HOLEP. Naturally, normally we see 100 grams prostate, 150 is big. More than 150 definitely needs expertise. Dr. Tanush Pal Bhatia is chairman, Institute of Laser and Stone Surgery, that is ILSS Faridabad. He started this center, I think a year back or 1.5 years. He is secretary, Haryana Urology Association. His special interest is advanced endourological surgeries like RIRS, HOLEP, supine PCNL, mini PCNL, super PERC, laser enucleation of bladder tumor, en-bloc, TURBT, laparoscopic urology surgery and uro-oncology. More or less all endourology and uro-oncology he does. He got 4 awards, including Urology Society of India's Dr. Sitaraman Memorial Essay Award 2012. His presentations and publication more than 40 international or national journal state conferences. 4 publications authorized chapter on HOLEP in USA Atlas of Endourology. Workshops organized LaserCon 2017 and 22. Cook Vista workshops, 4 workshops. Score RIRS workshop with Olympus April 2021. Luminous HTC Art of Enucleation workshop June 2019. A vast visiting neurosurgeon training workshop, which is very well known, and he has completed 14 workshops, multiple webinars, live surgical demonstrations. He has done Flexi ORS course in Kathmandu, East Zone Conference Ranchi, and HTC 2019 Cook Vista workshops, Faridabad, Madurai, UMD RIRS workshop, Patna, Laser Conference 2022, HOLEP versus TULEP, Hyderabad 2022 at my place, True Lab Endocon 2022, USA Urolithias Annual Meet PGH Chandigarh 2023. So with this experience, we find Dr. Tanush Pal Bhatia best in the recent past to particularly his monthly programs are very useful. My juniors have also gone, and they also thought that he gives a bit hands-on also on his patients. Certain points. So let us see how even for him 350 grams is a bit large, because 350, 400 grams is the largest I don't know in the world. So let's hand over the program to Dr. Tanush Pal Bhatia and listen from him. Over to you, sir. Thank you.
Thank you so much, sir, for this opportunity to be again on Pure Group. I think it is the most popular channel of urology, I think, not just across India, probably across Asia and across world also. And thank you from all of us for doing these programs regularly. I get feedbacks about my previous talk from so many people that before doing a case, they saw that talk and it was very useful for them. Similarly, I myself have used your talks, which are available on YouTube. For example, before a difficult pyeloplasty or other surgeries, when we listen to the experts and the step-by-step steps are discussed, and you ask question like a small child, like a beginner, despite the fact that you are an expert at everything, and that brings out what the audience want to watch, and it is useful for them and for their patients.
Thank you,
And
sir.
thank you also for such a detailed description of my profile. I don't know if I deserve that, but thank you so much, sir. I will share my screen.
Yes,
And
sir.
while I'm doing that, just a small disclaimer. Whenever we demonstrate HOLEP, or we want you to start HOLEP or TUFLEP, we want you to start with medium-sized prostates. Because in medium-sized prostate, the planes are very nice. Very nicely, you'll be able to get inside all the planes. Very easily, you'll be able to understand what is going on. Compared to that, anything more than 80 or 90 cc, generally for the person who is doing this, who is watching the surgery, it becomes difficult to comprehend where exactly the surgeon is. I mean, the understanding of planes and all is not as clear as it is in a small or a medium-sized prostate. So today we will be talking about a 350cc prostate, which I did recently, and we'll go through the video, as well as initially we'll go through some basics of holmium laser enucleation of prostate. So this is our institute, ILSS. We started this last year in August in city of Faridabad, where I have been practicing. So we know that HOLEP has a steep learning curve. That is one of the reasons why many people are scared to start, because most of us have not even witnessed it during our training during MCH or DNB. So mentorship is very important, especially in your initial cases. Even if it is not possible for the mentor to be there physically, we should be in touch with the mentor so that we can discuss finer points wherever we had difficulty, and the mentor can guide us how we can improve it. So one should do at least 20 cases in a short duration of time to understand the technique. Do not be very choosy about cases. Do not wait for that 100-gram prostate or patients who are on antiplatelets to start HOLEP. There is a way, there is a cascade which you can follow. I always advise first you do the laser VNI in your routine TURPs for 5 to 10 cases. Then you do the median lobe enucleation in 5 to 10 cases. And then you can go about doing the whole HOLEP. So you should do it frequently. So the difficulties one faces are loss of plane, bleeding, and hemostasis. Hemostasis is not as good as cautery with laser, but if you are in the right plane, generally the bleeding would be very less. The technique of proper morcellation, people are more scared about morcellation than they are about enucleation, because they are worried about bladder injury, and so they are scared. Again, vision during morcellation is important. If vision is good, chances of bladder injury are very less. So what do we need to do a holmium laser enucleation? We need a high power laser. This particular laser has an excellent tissue cutting effect. What we are using at my center is this machine, 150 watt Jena surgical machine. It's the first in North India and second in India. And I have been so far very happy with this machine, because it has some settings which have enabled us to take up bigger and bigger prostates, and we are able to do them quickly. Yes, it has good hemostasis and it's very versatile. You can do prostatectomy, OIUs, all lithotripsies, be it in kidney, ureter, or bladder. You can do endocollotomies, and you can treat urothelial tumors in bladder, ureter, as well as kidney. These are our basic instruments, what we use routinely. The laser bridges or the working elements. This one is from the Indian manufacturer, inexpensive. This is from Karl Storz. It goes with the usual Karl Storz inner and outer sheath. This is the morcelloscope, and this is the bridge that the connector that connects the morcelloscope to the outer sheath of the Karl Storz 26-French sheath, and this is the 30-degree telescope. Now we have thinner scopes also available, as thin as 22 French and 18 French, with which you can do the enucleation as well as morcellation. And this is the morcellator assembly. So same things, sheath, working elements, morcelloscope, and this is the morcellator. Now we have so many morcellators available in the market, and one thinks which one is best. So this white one is the Luminous VersaCut morcellator, which we were using since the beginning. Now, unfortunately, over all these years, Luminous or Boston has not made any changes in this morcellator. You have to change with time. You have to improvise. Whereas all other morcellators have moved towards the oscillating type of morcellator, which is much safer as well as quicker. So what we have at our center is this multi-cut, which is inside the laser machine itself. We did not have to buy a separate morcellator. And we also use sometimes this Tumi morcellator from Biored, which we have found very fast and useful. So when we talk about enucleation, I mean laser enucleation, it is a combination of enucleation and morcellation. We can do it using 3-lobe technique, 2-lobe technique, or en-bloc technique. I will just run through very quickly. 3-lobe technique is preferred for large prostates with a large median lobe. Laser incision is at 5 o'clock, 7 o'clock, and 12 o'clock positions. These incisions are connected, and the adenoma is pushed into the bladder with the laser energy. In 2-lobe technique, we make one incision at 6 o'clock, another one at 12 o'clock. We connect these two, and we push the adenoma as two pieces into the bladder. In en-bloc technique, the entire adenoma is enucleated as one piece, and that is passed into the enucleated and pushed into the bladder. Choice, I've already mentioned, three-lobe technique is preferred for a large gland with large median lobe. Two-lobe technique is preferred for a small gland. En-bloc technique is easier in smaller adenomas. After a certain level of expertise, most of us prefer to do en-bloc technique because it is faster than the other techniques. But you should do it only after at least 50 to 60 cases. Now, to do laser enucleation, we should know what is the plane between the adenoma and the capsule. So these transverse silvery fibers, what you see is the capsule, and whatever cotton wool fluffy you see is the adenoma. Here we can see one nodule of the adenoma, and you can see the shiny capsule. Again here, the shiny capsule, the adenoma. The shiny capsule, the fluffy adenoma. So if we understand this plane, half the job is done. If you know how to get into this plane, then you can go about enucleating it all around as well. So this is how we enucleate. You can see the capsule down there on this side. Now this is the adenoma. As we just lift the adenoma with the beak, some fibers stretch out, and those are the fibers we are supposed to divide with laser. So I will, yeah. So again, just I will discuss the technique of three-lobe technique. 5 o'clock incision, the first incision, it is Dippentil capsule, and we go till the Veru. Then we give the 7 o'clock incision, sorry, 5 o'clock incision, then 7 o'clock incision. Then these two are connected in front of the Veru. Although now most often we do place this incision before itself. Then we go about lifting the median lobe. It is pushed into the bladder. Then we give the 12 o'clock incision. We do, after this, we do the apical release. How is the apical release done? I will just show you. We come back to the level of Veru. We see till where the prostate is extending. Then we make an incision on the, which is separates the apex from the adenoma, from the sphincter, sorry. Which separates the sphincter from the adenoma. So we give an incision from 6 o'clock to 3 o'clock, and then from 12 o'clock to 3 o'clock incision. And then on the other side, from 6 o'clock to 9 o'clock. See, the hand movements are very important. And then from 12 o'clock to 9 o'clock. So this way we separate the adenoma all around from the sphincter. How this helps? It prevents the stretch on the sphincter during the further enucleation, which in turn prevents stress incontinence. So this is one of the most important steps to prevent stress incontinence in laser enucleation. So after this, our incisions are complete. We go about enucleating the left lateral lobe, same way as I showed for the median lobe, and then the right lateral lobe, and then all the three are morcellated out. Some tips during morcellation: hemostasis before morcellation is must, so that the vision is good. The bladder should be kept full. How? The outlet should be closed, and we connect two bottles, and we both open both the bottles. I personally do not use any sort of pressure pack or any pressure on the bottle, and I advise also not to use. So we just use gravity, but we open two bottles and we keep the outlet closed, and the bladder is kept full, and the attendant keeps our assistant keeps checking whether the bladder is full or not. And one should not hurry in morcellation. You can be slow and steady, but be careful to avoid bladder injury. I'll skip this video. Just a small video of the two-lobe technique compared to three-lobe technique, where we give 3 incisions. In two-lobe technique, we give only 2 incisions. There is a reason why I'm showing you the two-lobe technique, because this is what I'm showing here is the classical two-lobe technique. And what I use for very large prostate, like the 350 cc that we are discussing today, is a modified two-lobe technique. So in our two-lobe technique, first we give an incision from 6 o'clock to verumentanum. See, that's the Veru. Then we turn. Then another incision from 12 o'clock till the distal limit. Of course, we mark the distal limit beforehand. Deepen this incision. We'll do a little zigzag movement there that creates a tough trough, so that the movement of fluid inside the fossa is nice and the vision is good. Let's forward this a bit. And then we start lifting the lateral lobes. Here I'm lifting the left lateral lobe. First we go from below above. You can see we are dividing the fibers. So that's how we go about enucleating the lateral lobes. Basically, I wanted to show the incisions that we gave in a classical two-lobe technique. Now I'll just pause this here and move to the next part. So this is how the prostate looks after an en bloc technique, wherein the entire adenoma is separated or enucleated from the capsule as one piece. You can see the whole adenoma is separated as one piece, like we used to do in our open prostatectomy, and then that is passed into the bladder. Okay, these are the last few fibers which are divided, and after this, the entire adenoma will go into the bladder, and then that is morcellated out as one piece. So the enucleation is faster, and the morcellation also is faster because you don't have to chase different lobes during morcellation of after a en bloc technique. So now, why I showed these two techniques? Because in case of a very large prostate like this one or anything above 170, 180 cc, I do not go for either a classical three lobe or a classical en bloc or a classical two lobe technique. What I do is first I take out the bigger chunk. Generally, the bigger chunk is the median lobe, which we can see also in our MRI images and in our ultrasound is nicely projecting into the bladder, and it is attached only at the floor with the capsule. So first I do the median lobe enucleation, just like our three lobe technique. We make one incision from 5 o'clock to 6 o'clock, 5 o'clock to Veru, then another incision from 7 o'clock to verumontanum, and then we go about enucleating the median lobe. Now what happens? Medial lobe goes into the bladder. There is a nice space created inside the fossa, which allows fluid to come in. As you will see in the video which I will show you, initially during the enucleation of a large prostate, the vision is not that great because not too much fluid is coming into the fossa. The circulation of fluid is not that much. And even in the bladder, actually, it occupies so much space that there's not much place for fluid. Anyways, so first we do the median lobe enucleation, then we have a nice space, we do the hemostasis, and after that, the rest of the prostate, both the lateral lobes and the anterior part, I take out as one piece. So I do that part as like a en bloc polyp. Okay, so the entire thing is not en bloc. I do a median lobe enucleation, and then rest of prostate I take out as en bloc. This is my modified two lobe technique for very large prostates. Now we'll start with the video. This is the specimen, what you're seeing in the picture. This is the specimen. You can see the volume of the gland there. This is a 500 cc kidney tray, and most of it is filled with the tissue. Hi, good morning. Today we'll be operating on a large 350 cc prostate using the Jena 150 watt laser. The setting we will be using are these 3.5 joules at 40 hertz, which is 140 watts. And this makes the procedure very fast, and that way it is very good for large prostates like this. So as I mentioned, I used a setting of 140 watt, which is possible only in a 150 watt laser, thereby bringing in the advantage of this very high power laser. And as we know, the prostates that we are treating, more and more we are seeing bigger prostates. So this is the cystoscopy. There was a small false track from a previously attempted catheterization elsewhere. And we are going into the prostate, and you can see how big that prostate is endoscopically. Large lateral lobes, large median lobe. And obviously there is no chance of looking at the uretary orifice here. You can see it is just touching the opposite bladder wall. You can see how close the bladder wall is to the prostate. So I realized anyways, without a continuous irrigation sheath, I will not have good vision. So I immediately, after this, I did a Otis ureterotomy, which is standard for me, and I passed the laser resectoscope. Now, as I said, I did a modified two-lobe technique. So my first step was to make this incision here. It is believed that just proximal to where is the best place to find the capsule, because the tissue is least here. So I made that incision V-shaped. It was a vascular gland, congested gland, and you can see we are reaching near the capsule. You can see those bigger bleeders near the.
Sir, pause, please.
Yes, sir. Yes.
The first question, because at the end, if we ask a lot of people, now people are joining more.
Yes, sir.
Nearly 80 people have in and out. So first question is, when you make first incision at the veru,
Yes, sir.
the submucosal bleeders and the some prostate substance bleeders
Yes, sir.
annoy us for 5 minutes, first 5 minutes.
Correct.
Some people ignore and proceed happily, like experience like you. Some
Yes.
will be pointing, deep, going, again bleeding, coming, wasting half an hour.
Yes.
Should we find a capsule and go ahead with the bleeding with good irrigation for 10 minutes so that things will get control because you are onto the capsule, which
Yes.
is better?
Sir, I'll just show you what happened here.
Here
and that
also
was-
I am seeing
Yeah.
you large bleeders, you continued, it looks like.
Yes, I'll show you, sir. The bleeder is actually from the adenoma.
Yeah.
So it usually will be. And you are anyways going to take out the adenoma. So
Yes.
that bleeding will stop after that. If we waste time on controlling the bleeding from the adenoma, it is of no point.
No point. No.
Because laser will not be able to control that, and we will be wasting time. And if I'm seeing the capsule there, I know that I am in the right plane.
Okay. So you give less importance to this bleeder.
Yes, sir. These
For a
bleeds
short
are
period of
expected. Generally, in a smaller prostate, the bleeding would stop when you reach the capsule.
Yeah.
And when we do this little shelving sort of thing there, as we lift the adenoma up, then the bleeding would be very less.
Yeah.
Only when we come back to this area after the median lobe enucleation, you might see some little clots and all there.
My
And there can
second
be some
question
bleeding.
here.
Yes, sir.
My second question here. I have seen most of the people of your caliber, they make plane at 6 o'clock,
Yes.
go on either side at 5 and 7.
Yes.
They don't turn immediately. They keep on going on the median lobe, or whether it is present or not on that layer a little further, 1 centimeter, 2 centimeter, take a comfortable stand, then come on towards the veru.
Yes.
Before giving on either side 5 o'clock and 7 o'clock incisions, is it better to make a proper base at the level of the 6 o'clock position, 5 o'clock to 7 o'clock position for 2-3 centimeters, correct? Or you can directly go to the lateral lobes?
Sir, you can go directly also. How it helps is, as I was saying, that it is the best place to see the capsule. And ultimately, enucleation is all about dissecting the adenoma from the capsule. Once
Okay.
we see the capsule, all of us are tempted to follow the same plane,
Okay.
which you can do throughout also till the bladder neck. Problem is that if we don't make the 5 and 7 o'clock incisions at the right time, we can do undermining of the bladder neck.
Yeah.
We go blindly. So that is why somewhere after the mid lobe, we prefer to go to the 5 or 7 o'clock position. Then we deepen the incision till this, and we make this shelf into a U shape, the sort of incision.
The third question again,
Yes.
just continuation. After that, you play the video. When you are giving 5 o'clock and 7 o'clock incision from the bladder neck to the veru,
Yes.
there are two ways. One, exactly abutting the lateral lobe, exactly too much going towards labor lobe. One, thoda towards the median lobe, which is benefit of doubt, because many times when you go towards the median lobe, later on when you are enucleating the lateral lobe, it becomes a tedious job. If you cut off more with the lateral lobe, the median lobe anyway will come out easily for a junior. So should we be cutting the 5 and 7 o'clock towards the lobe, median, or towards the lateral lobe? A benefit of doubt.
Sir, I prefer to cut towards the median lobe. So basically, as I'm coming back towards the veru,
Okay.
I go medially as well as distally. It is just like the BNI, what we do with our Collins, our knife, hot knife. So I do it in same way. Thereby, how it helps is it enucleates the median lobe also partially. It prevents my undermining of the bladder neck.
Okay.
If I go into the lateral lobe, generally that happens when one creates multiple incisions. And that is the most common mistake that a beginner does.
Yes.
That when we come from bladder neck to veru, they make multiple incisions and they get lost in that incision where to go.
Then you will go from distal to proximal to distal incision.
Sir, proximal to distal, from the bladder neck to the veru.
Single cut in one direction towards the Veru.
Yes, sir. Single cut in one direction towards the Veru. One should not stop in between. Even if you stop, complete the incision towards the Veru.
Okay. Okay.
Otherwise, what happens is you stop in between, you come back from there, then multiple incisions, multiple cuts, stopping at multiple levels.
Correct.
Then you
Okay,
will
sir.
not find the tissue in. You will find the tissue in between, which will always trouble.
Yeah, that tissue will trouble.
Yes,
Or else some people do horizontal cutting, separating a little bit, so that you will have a big throw instead of one incision, so that they will have idea where they are going. That is also
correct. Earlier, I used to do that as well. So that you.
Like it takes time.
Yes, sir, it takes time. It takes
Yes,
time.
sir. Okay, proceed, sir, with video, please.
So now I'm starting with the 5 o'clock incision here. As you can see, because it's a very large median lobe, very large lateral lobe, I have turned my scope. With the fiber now, it is coming at, you can see at around 3 o'clock. So to get into that groove, to get into that exact 5 o'clock position, I will just go back and start again. This is done. Yeah. Turn the scope.
Yes.
I've turned the scope to get into that groove. On left side, there was a good groove. On right side, there was not much of a groove. So here we use the natural groove. And in one cut, we made an incision from the bladder neck till this point where we had already dissected.
Yeah.
You will see, sir, my incision will not stop in between. Every incision will come till the.
You are continuing whatever incision you are giving, continuing up to Veru.
Yes. One more
Not
thing
stopping and going.
One more thing is, when I am cutting tissue, my direction is a little bit downwards. When I see the capsule at places, because the capsule is not round how we want it, at times it will be up and down. So then we little lift the, I make it parallel to the capsule, but if there is tissue, a little bit dip it or bend it, the laser facing down.
Such a large gland, do you have any role of keeping? Sorry, interrupting, keep playing.
No, please.
Is there any role of keeping an drainage from above through the bladder?
There's
Just
no harm, sir.
curiosity.
There's no harm. There's no harm.
Because sometimes this is annoying lack of vision will be there. One needs expertise and focus on exactly where you are going every time.
It is safer to keep, sir. Safer to keep.
In case junior doesn't find vision nicely, because till you cut the median lobe, as you said, water outflow logistics will not improve. Isn't it, sir? Such a big gland.
Absolutely
correct. A big gland.
You can keep an outflow above. Some people keep in every case of HoLEP.
Have you ever kept, first of all?
I have kept, sir, in the cases where the urethra did not accommodate any of the scopes. I used the OIU scope to do a HoLEP once, and for outflow, I kept RPCNL Alkens cannula as suprapubic drainage.
Okay.
Once I've done that.
Okay. So this incision will take time, sir. You said
yes,
depth is more.
It is a very big prostate, and we are just cutting. But what is important is that it should be in the same place.
Sir, don't mind the hook will incise very fast is my feeling. But when I discussed in Pure, they said no. Even laser fiber also cuts very fast. But hook, in no time you reach capsule. It's a very powerful monopolar cut.
Yes, sir. See, now I've reached the capsule, sir. Near the bladder neck. You can see the fibers there.
Yes. So you are turning every time a little bit. Just slash like this.
To get into that place. Many times we won't even be able to enter the bladder unless we turn like that. We use the 30-degree advantage of the telescope here.
That's a valid point. Very, very valid point here. You are turning, going, and then coming back in a neutral position.
Yes, sir.
Excellent.
So very large prostates will be more vascular also. They will be chronically obstructed, recurrent.
Now I am seeing properly you reached the horizontal fibers are seen.
So, but there is tissue in between. So
this middle part of the gland, lot of tissue.
Yes, sir. And you have to cut through the tissue. Even those nodules will be there. We have to cut through the nodules. To the other side.
Yeah.
It's 7 o'clock. There was not much of a groove, so I'm creating a groove here. And I have not been able to see the ureteric orifices still.
Okay. Because you are incising no harm at the moment.
Yes, sir.
This is a very large gland. Bulk is more here.
Yes. Bulk is more in the median lobe also, sir.
Median lobe also. Length, okay, acceptable. But bulk, it looks like completely opposite wall. lumen of the urethra is not opening up at all.
Yes, sir. So we are deepening this.
Sorry, your laser settings are?
This is 3.5 joules and 40 hertz, sir. 140 watts.
Laser fiber burn also will be there, na, sir?
It will be there, sir. It will be there.
Such amount of laser power.
But it is much, means, see, there is a bridge of tissue there between the lateral and median lobe. It was missed. Now I'm dividing that. So yes,
Okay.
there will be a burn of tissue, sir. But
Now
still,
you can see
fibers
the
are, that was the orifice which I saw.
Yeah, yeah. I can see the
This
orifice.
is a 2x speed, sir. It is a little fast, but
Yeah, no problem.
so that
These surgeries will take time. We can't show in half an hour everything. More than 100 cross viewing people. It's an interesting subject nowadays. Everybody wants enucleation because of the thulium fiber laser and Holmium. Both are available easy. And rewarding results also, I think.
yes, sir. These clots are where my first incision was.
Yeah. If you wanted to any
You can
bleeder,
see
you
the
wanted to, yeah, now you are
all there.
turning completely horizontally.
Yes, sir. See, here we can see the capsule here
Yeah,
and the adenoma here. And now
Yeah.
my fiber is parallel to the capsule.
yeah, yeah.
So we are scared in a large prostate even to go too deep, because we are scared, planes will not be that well defined. We can end up going too deep. So it is important to make it just parallel when you see the capsule. And where required, we can cut towards the tissue. So every time I have to turn, enter, that is there, sir.
And do you keep this monitor exactly at your neck level? We feel neck
Yes,
pain
sir, I keep.
after 1.5 or 2 hours.
I have 2 operating rooms, sir. One operating room, I have a monitor on a pendant.
Okay.
Where I can keep it where I want. If
Yeah.
possible, I keep it right above the patient. In my other operating room, I keep the monitor right across where the Boyle's apparatus is there. I move the Boyle's apparatus away and I keep it right across at the level of my eyes. And that way the fatigue is very less.
Yeah.
Also, it's important to blink your eyes during HoLEP because you will be continuously watching the screen.
Watering of the eyes also happen a little bit.
Yes, sir. Dry eyes is common.
It's a problem.
Yes. So there I'm lifting it from the median lobe, sir.
Yes,
trying to connect both the incisions.
Yeah. Some people call hockey stick like that, something.
Yes, sir. Near the
bladder neck.
Near the bladder neck, I go hockey stick. That is again to prevent undermining. Here I felt I've gone a little deep. So I'm just trying to find I can see the bladder neck. Now I can confidently cut, sir.
These vessels which are like apron are good sign of good plane?
Yes, sir. So I feel this is the advantage of HoLEP, that you see those vessels and you can coagulate the vessel itself rather than trying to look for a bleeder hidden in the tissue.
Okay.
If there is a bleeder, mostly there will be some tissue there.
This surgery took how much time? There was some deep and you immediately came up.
Yes, sir. You see, this is deep, sir.
This
so
is
immediately
deep.
I have corrected the plane.
Seconds you are correcting that.
Yes, sir. Yes,
Had it not been, it goes deep.
Yes, sir. I see the bladder neck again.
In millimeters, you have corrected.
Yes, sir. Yes, yes. That is very important, sir.
That is very important. That matters a lot. Otherwise, you realize after some time, then it's not good.
Yes, sir. That's the whole median lobe going, sir.
Very nice.
Some fibers, and now it's gone. Now, just like TURP, we need to do the hemostasis immediately after enucleation of one lobe. So we spend some time on hemostasis. If you see a bleeder, wherever I see some red patches, I generally coagulate with the laser.
Yeah.
Now, after that, we have to mark our distal limit. So anteriorly, there is no verum montana. So we have to decide where we need to stop anteriorly. So we make this mark anteriorly as a distal limit. And then, although in this case, I did not place a 12 o'clock incision. If I was doing a 3-lobe technique, I would extend the 12 o'clock incision from the bladder neck till this point. Now I'm marking the distal limit anteriorly. Just see the strain on the telescope, sir, now, as I go deeper there. You can see the half mooning happening on side. This is the place where the telescope gets damaged anteriorly. So it is important, after making this distal mark, First, I try to reach till the capsule. Then I try to dissect also a bit towards the bladder neck. Ideally, in en bloc, I go right till the bladder neck. But every case, it is not possible, like in this case also. So we made a incision there just as a distal marking and deepened it till the capsule.
There
There
in this.
Yes, sir. See, there will be a strain, and these are rod length systems, so they will fracture, and you lose the telescope.
Was suspensory ligament was not a problem in this case?
No, not a problem in this case, sir.
Was the penis was lengthy or small?
No lengthy, sir. It was decent. So now we do the apical release, as I showed. First from 6 o'clock to 3 o'clock position. Then from
Already released at the top.
yes, sir. Now coming from 12 o'clock to 3 o'clock, that was the distal limit mark there. From there, I come to this 3 o'clock position, sir.
Yeah. Do you recommend any high pressure flow, if at all?
No.
Any?
No,
Sometimes
sir.
we say press.
No, sir. Not of any benefit.
Not
If
of any
at all,
benefit.
what you suggested, keep a extra outflow, if at all. No extra pressure. You
No
have to
extra.
be patient. If you want to do enucleation, you have to be patient. Now on right side, sir, apical release. 6 o'clock to 9 o'clock, 12 o'clock to 9 o'clock again.
On the other side.
Yes, sir, on the other side. See, in a large gland, some bleeding is expected, sir. So and it's very difficult to find that exact bleeder.
Yeah.
Better not to waste time.
Yeah.
Go about
But
enucleation. Yeah. Now I've
as
started the enucleation, sir.
fast as possible.
Yes, sir.
Yeah, proper left side.
Now one of the advantage of this 140 watt is that the bubble that is created is bigger bubble. So if you keep at the right distance and the bigger bubble, when it bursts, it separates more tissue. So you dissect more tissue compared to a usual 100 watt setting or 80 or 70 watt setting. That is how it becomes faster, sir. Less than 100 cc prostate, nowadays we are finishing in 30-40 minutes most of the times.
Yeah.
Yesterday, my
For
188
all the
cc.
viewers, now 135 viewers have viewed. For all the viewers, that is the thing. We have to understand that enucleation is not that slow in a less than 100 grams, which is 90% of the cases.
Yes,
so even after 60 grams, enucleation is better, I feel. If it's only 20-30, okay, fine, it's a different issue. But more than 60 grams, enucleation is a good surgery. Hello? Tanu sir? Tanu sir?
I came back to where it is defined. Whenever we feel that we are not in a good plane, we come back to where the plane is better defined, and from that area we come back to the poorly defined plane. So anteriorly, when we are going blind towards the bladder neck, sir, there is a fear of going outside the bladder. So I change the direction of fiber a little bit facing downwards, always in this area, and walking towards the bladder neck. Now gradually again I'm moving towards the bladder neck. There's a lot of tissue there in the way. Now you can see the bladder mucosa there, thin bladder mucosa, and now the bladder is open. We can see the bladder neck, some clots inside the bladder. So we always first we come from below above, and then we come from above below, and we connect both the planes, and we go about enucleating the lateral lobes. That's the further dissection of left lateral lobe. As you can see, almost all of the left lateral lobe is dissected now. Only few fibers attached. Almost all of the left lateral lobe and the anterior part of prostate is enucleated. And then again, we do the hemostasis after completion of left lateral lobe enucleation.
Obviously, this is a 3-lobe technique because it's very large.
It is a modified 2-lobe technique, as I call, because I'm not making the 12 o'clock incision here. So the median lobe comes out at one piece, and both the lateral lobes and the anterior part come out as second piece.
So anterior, you did not
Now I'm
continue.
starting with the right lobe.
Anterior lobe, you did
No, I
not
did
cut
not,
it
sir.
up to the, you did not divide completely.
No, no, no. No, I did
Okay.
not.
Does it make
So now I
any,
started with the right lobe.
does it make it
Sir, it makes it faster. En bloc is always
faster?
faster, sir. Yeah, yeah, en bloc is faster. So rather than giving one incision, then trying to match incision from here to here and here to here, and we go right across. Take the opposite side when we do en bloc, sir. There's some bleeders there, but I feel while if we reach the correct plane, the bleeding decreases. Again, bleeding was
So
more
everything has
from the
one.
adenoma than from the capsular side.
Yes, yes.
Some tissue there, but we can see the capsule here. This is the capsule, this is the adenoma. Capsule, adenoma. Capsule, adenoma. The nodule is there. We try to take that nodule also out. At places we might go a little deeper, but then you have to correct the plane again immediately. Sometimes there will be some pus pockets also in such large prostates, which will hamper the vision. Just come back from there, and when we come back again, the vision is all okay. So now coming from above, below. Is it a little too fast to understand, sir?
No, no, sir. No, no, no. At least I am able to understand because I know where you are and what problems come. I am closely watching. If you come in between the lecture, it is difficult.
Yes.
That
That's
is the
true.
problem with enucleation. Even if you give handover to somebody, they cannot take over.
Absolutely correct, sir. Absolutely
Not
correct.
like laparoscopy that you do
Yes.
mobilization of colon and somebody takes over. Here you need
Absolutely.
orientation from beginning of the. If you want to learn enucleation, somebody video, you have to see completely from beginning.
Correct, sir.
Otherwise, it is
And
difficult to
even as an
understand.
expert, it becomes difficult if someone else has started the enucleation. I'll be frank with you, sir.
Yes, yes, yes. Or else if he's watching continuously in the theater, okay. If he goes
Yes,
out and come, I feel this procedure is technically demanding, sir.
it is.
Of all I have done, it has some especially when you are curving the lobes at the middle part of the gland, you need a little imagination like in PCNL. When you are moving your this thing,
Correct, sir.
you can go into gland.
Now, there is some bleeder here, which is, yes.
You can go per. You need a little bit of imagination where the curve is going. I mean,
I agree, sir.
practice also on practice on smaller glands also better.
Yes, sir. Such
Around
glands are to be attempted after a good amount of whole life experience.
yeah. More
Otherwise,
than 150 grams casually you should not attempt.
yes, sir. Yes, sir. And anytime we lose plane, we come back to where it is better defined. There was a bleeder here, which we were not able to identify, find it. So we continued with the enucleation. We thought after taking out the right lateral lobe, we will see. As you mentioned correctly, we have to keep in our mind where the capsule would be. And anytime we feel we are too deep or too superficial, we have to correct the plane. Because one of the tricks to decrease bleeding in HoLEP definitely is to be in the right plane. Some fibers of the bladder neck there. So again, we are coming from above, below, laterally on the right lobe near the bladder neck now. Whatever bleeding I was getting was from somewhere this area only.
Yeah. And three-dimensional idea quickly coming where you are is also important, sir.
Yes. Now I had left some tissue there, And that was one
Yeah.
of the reasons for some bleeding in that area. So I have gone again to the capsule where I found it. And from there, I'm coming from above below to take out this tissue also with the adenoma.
The Homeom has this advantage that it quickly takes out the small nodule again.
Yes, sir. Yes.
That,
Dissection, I believe, is very good with Holmium, sir. The way it dissects tissues is nice.
dissect tissue. If you miss the plane in thumium, everything looks like capsule and it becomes brown.
Yes.
Charring is more. The tissue is cut.
Yes, sir. And yes, you will be lost. I mean, even I in last prostrates, you will feel you're lost somewhere. And where was I? Now where I am. So we go back again to the bladder neck, find where the right plane is, come back from there, and divide whatever is remaining, staying on the capsule. They're all overhanging inside the bladder like this.
Really painful job, sir.
But it was not, sir. It was quite fun.
Somebody asked a question, anytime did you feel I might not be able to complete? Did you keep a backup plan? Deepak,
I had consent for open surgery, sir, always.
Good.
The patient's family
Very nice.
asked me, do you have any experience in open surgery? I said, yes, I have. So it is important to have some experience in open surgery also to do this. If you don't have, and if you feel a difficulty, you keep a surgeon standby who has experience in open surgery, especially a transvesical flares.
Yes, some senior surgeon for putting open. Yeah. Sir. Very, very valid point.
At least he should be on your call that whatever required he can come. So I knew that even if it doesn't succeed, I would do this one. But I had done up to 300, 320 gram, 340 cc also earlier. So I was confident that I will be able to finish it. Anyways, now after the enucleation part, I had to see where this bleeder is. And I tried to control it with the laser. As I mentioned, there would always be some tissue there where the bleeder will be there. But it was just not stopping with laser, and I was not able to see it because it was a bigger bleeder. So I use the ball electrode, and this is something we should not shy away from, even in a smaller prostate. If the laser is not able to control the bleeding, use a ball electrode, because during morcellation, you need good vision. If the vision is not good during morcellation, then you can enter the bladder, especially in a large prostate like this. Fossa like this will also bleed more than a usual HoLEP or a TURP. So at the end,
diffuse wounds also will be.
Sir. Yeah. So now I'm just buzzing that area and trying to control the whatever bleeding is from there anteriorly. Also, in these chronically obstructed prostates, there will be those larger venous bleeders near the bladder neck, dilated ones. So they will also trouble at the end. Although most of them will decrease because of the pressure of the bladder, some of them will still be bleeding. With some hemostasis there. Also, we always counsel these larger glands for a staged morcellation. So if there is any issue, if the vision is not good during morcellation, or if the tissue is too hard and it is not getting morcellated out, then we can always stage these glands. Any gland more than 120 cc, I take a consent for stage morcellation, sir. And the stage we plan on the next day. Now, because it was a large gland, I kept 2 morcellators with me. One was the Toomey one, and the other one was the one from Jenna Surgicals. So I started with the Toomey morcellator. But this Toomey morcellator has a smaller aperture. And in some time, I shifted to the Jenna morcellator, which is a bigger aperture. It cuts and sucks out more tissue, I felt. So till I'm seeing the blade, I'm seeing the tissue, I can differentiate the bladder wall from the adenoma. that is good enough vision for me, sir, as you can see here. If I cannot
Yeah.
see these three things, then I will not proceed with oscillation. I will again put in a ball electrode. I'll spend more time in hemostasis, then I will come again.
So it
If there
needs
is
a lot of
yes, sir, it needs a lot of. So if sometimes if there is a venous sinus bleeder, which is not stopping even with coagulation, then one can put in the catheter, start irrigation, give some traction if required, and do the musculation next day also. So we always press the pedal half, catch the adenoma, come to the center of bladder, and then we do the musculation. Catch it, come to center, and then musculate. Just forward a little bit, sir, because it becomes boring for people who are watching, I think.
Yeah.
So this is the Jena oscillator, sir. If you can appreciate the wider,
Appreciated.
the wider
I can clearly
aperture.
appreciate the speed.
Yes, sir.
This they give inbuilt with laser in a package.
With laser, sir. There is a disclaimer. This part of the video is 8x also.
Is
It is running at 8x speed also. So speed a little bit.
okay, no problem. I this is a major surgery, 3 hours like that. We cannot show it in half an hour. Naturally expected.
Yes.
But 8x means tissue is seen.
Yes, it is seen.
It's not the tissue is not seen.
Yes, sir. One more thing, we have two pedals in the Jena machine. So with left pedal, we do suction and the right pedal, we do oscillation. So if you just want to take out the clots, you can just use the left pedal for suction and all the clots come out through that big aperture, sir.
That will be in left leg and right leg?
No, sir, same leg. Same, the yellow and the blue pedal basically. The yellow pedal is suction, blue pedal is suction and oscillation.
In starch, it is half press, full press. थोड़ा confuse हो जाता है उसमें.
Yes, sir. Yes, sir. Even our old Versacut was also like that only. And in
But
fact,
people say Piranha is the best. Do you have experience? Piranha is very good, it
I have
seems.
used once or twice, sir. Somehow I.
The worldwide Piranha जितना name है उतना I don't know.
Yes.
But it's costly also.
What I have seen, I think Piranha has blades on both sides, so I feel a little scared with that. Compared to that, all these newer oscillators are one side covered and only one side the blade is there. So I feel these are safer somehow.
Even I feel I start. I am reasonably if one side is there, so you can see the blade. What are you doing here with loop?
Now, all those small nodules which are left in the end, sir, I'm just taking them out with the loop. Yeah. And also, I was trying to inspect the cavity for anything that is left. I mean, floating. Whatever a little bit tissue I see on the capsule, I do not try to remove it, especially not with a cautery.
Why, sir? Capsular perforation हो जाता है.
Yes, sir. Because we are right on the capsule. Whatever we see, it's very minimal. Even when we try to take it out with laser, we realize that it was just a flap, small flap. So that is the, we can see the sphincter all around, sir. The Veru there.
The good part is mucosa is fully intact.
Yes, sir.
Great.
Above also.
Above also. Above, I mean to say.
Yes, this is the Veru. That is a whole big cavity. At some places, it is deep also. It is like 3 prostates in a series. That's little bit tissue is there. It's okay. I don't want to do cosmetic things.
Yeah. That's a big gland and all areas, 90% capsule is in 99%.
That is the orifice, sir. Left orifice.
Yeah.
Right orifice there. That is the right orifice. And the rest of the bladder. So total procedure time was 130 minutes for me, sir.
Yeah. At least urethra or the bladder neck, the pulbomembranous region is intact.
Yes, sir.
Let's take some questions.
Yeah, that was the tissue, sir.
Great.
Weight was 347 grams.
Very nice. Very nice. So, if the resectoscope, yes, sir, please, stop here. If the resectoscope does not reach for various reasons, either because of suspension ligament, long penis, long prostate, or the obesity leading to the tubular prostate. What is the option if you don't see the bladder neck? In the beginning only, if you don't see the bladder neck, will
Yes.
you dare to do from distal to proximal? It's rarely happens, but
Sir, if I do from distal to proximal, it will only increase my problems. I feel it will increase my problem. Rather, I would still do somewhere in the midland and come here. Then, as the fossa opens up and creates, then use it. Usually, we are able to manipulate little bit. If we push, there will be a little bit of buckling of the urethra,
yeah.
but we are able to reach. So far, touch wood, I have not faced that situation where I have had to change to anything. But we have to foresee these problems. Once
Why?
I was invited to, so we have to examine in the OPD how is the penis and everything, and how big is the gland. Once I was invited somewhere for a surgery, and patient was from African continent, and when it was exposed, it was a very long penis.
Yeah.
And I thought how I will go enter the prostate also. Now, luckily for me, he had a hypospadias, so I could complete. So
The other question is, why
we can
in
do a
TURP,
penile when required, sir. That
why
is the
in TURP like mini perc, micro perc, ultra mini perc, the 26 is staying for a long time, sir. Unfair for an Indian Starch company, Wolf company. Of late, proper 22 by 80, 20 by 22, 22 by 24, they should be freely available. The problem is with telescope, you have to buy a telescope. The loop is also become small, I understand. What is your, out of 100 patients, how many penile urethra are small for 26? What is your opinion, honestly? Because once
out of-
damaged urethra is panurethral stricture.
Yes,
It's a disaster.
correct. Sir, our Indian urethras are not that roomy. It is a known fact. That is why I am using Otis urethrotomy in every patient. Every patient, even in catheterized patient, I do a Otis urethrotomy. So, if you ask me, out of 100, I think probably 40 to 50 only have a very capacious urethra, maybe even less.
Yeah. That's
Most of
fair
them are.
answer. That's a very fair answer. I have seen 2-3 patients in my 10 years panurethral stricture, or irrespective of if inflammation is there, infection is there, catheter damage. I mean, one area of stricture
Thank
also
you.
will trouble post these procedures.
Now,
Anyway,
for
that is
me,
a totally different subject.
yes,
Second thing, sir.
I feel, sir, if I'm trying to clear one obstruction, I should not be creating another one. And with Otis urethrotom, luckily, I have been successful in doing that. 22 French sheath is the answer to this.
Yeah.
Unfortunately, for a large prostate, I cannot use it because definitely my lens will go. Definitely, it will go.
Lens
And
will.
even the aperture is smaller, the field of vision is smaller. So it is a challenge. So up to 70 or 80 cc glands, we can easily use the 22 French sheath. And another challenge is to have the morcellator of that size, which currently I don't have.
The other question is, this is a very practical question I'm asking. When you are doing 3-lobe,
Yes, sir.
you initially made incision on either side 5-7.
Yes,
You
sir.
made an incision between the distal most part connecting the anterior to posterior.
Yes, sir.
Then you made a groove in the distally nicely. Some part of the gland is nicely enucleated.
Yes, sir.
After that, there is one way that you continue distal to proximal all around like that, continue.
Yes.
Or go inside bladder neck, come from 12 o'clock to 3 o'clock, 12 o'clock to 3 o'clock, or 6 o'clock to 3 o'clock, 6 o'clock to 3 o'clock. Whether there are very specific question. Again,
Yes.
I am asking at a preliminary level.
Yes, sir.
You made incision at 3. You
Yes.
made incision at 5 and 7 nicely up to capsule.
Yes, sir.
In fact, Manke Jao, you have enucleated the median lobe also. I'm not asking anything about median lobe.
Yes, sir.
Now you have given incision anteriorly right from bladder neck up to the sphincteric region.
Correct.
Now you have connected also properly at the paraveru region, both where
Yes.
mucosa is detached.
Yes, sir.
Everybody feels up to this level, bah, very well done.
Yes, sir.
After that, the story starts because large amount of gland will be in the middle and you should have patience. So
Yes.
usually I start from distally coming from the for 6 o'clock to 3, 6 o'clock to 3, I try to go anteriorly. Thodi der tak it will be okay.
Yes,
But
sir.
after mid gland region, my scope feels difficult to fit into that groove and I am exerting some pressure.
Yes.
Then I will switch over and go to the 12 o'clock and come from there. And
Yes.
by chance, if these two planes are not same,
Yes,
you
sir.
are doing the double job of removing the paper. One paper removed, another paper removed, then you have to mix up both the papers.
Correct, sir. But
This is the problem, sir.
but you're doing the absolutely right thing. Because the moment you feel some tension in the enucleation happening, that
Yes,
means the adenoma is fixed somewhere else.
yes,
It
yes,
is in
yes.
the roof.
Okay,
Then you release it from the roof
okay,
and you come above down. That is how the tension gets relieved and the adenoma moves little more towards the bladder.
okay.
It is obvious, sir, when we are coming from below above and we are coming from above below, it is not possible that we'll meet here.
Yes, yes,
We'll
yes,
be here
yes.
and here.
Yeah, yeah, yeah.
So if we come little towards the sphincter,
Yeah,
where we have connected it already completely,
yes, yes,
we
yes,
will
yes.
see those fibers in between.
Yeah, yeah, yeah.
And then we have cut those fibers and then both the incisions will be joined. That is why at places we are too deep and at places we are too superficial.
Yeah, yeah.
Basically, we
Because
have to find
capsule
those-
is also not a one layer, na sir. It
Yes,
is
sir.
not exactly 1 mm.
Absolutely, sir. Absolutely. It is multiple layers. So we will be in those 2, 3 layers. We have to find the right place. And the best thing, and that is why learning en bloc is important, is that you should know how to take it out from the capsule. So
Yeah.
even if there is some tissue remaining, we stay right on the capsule, then we can correct the plane. Of course, as we are moving more towards the bladder neck, we have to be mindful not to go outside the bladder.
Second question. When I am doing the left lobe being a right-hander, I feel comfortably I have done.
Yes,
On when the right side, when I start, I feel it is easily enucleating.
yes, sir.
For 5 minutes, it enucleates as if it is going to finish in 5 minutes.
Yes, sir.
But suddenly, your hand will not rotate in the middle gland this way or that way. Then it will take double the time of the opposite gland.
Reason is same, sir. Reason is same. That part of the gland is you have already released from the capsule. Part of it is still attached. Whatever is attached is what is restricting you from moving. So again, we have to go from above below. Rather
Fourth
than
question.
yes,
Some
sir.
people like Manohar,
Yes, sir.
they use in a pencil-like fashion, all around they move like this. They
Yes.
don't grip this thing. They hold it.
Yes.
They will be moving like this. They will be moving like this, like this, like this, like this. They will go. They don't use other hand and exert. I mean, something. I mean, easy cases,
Everyone
not
has a
very
different
difficult
way
cases.
of doing it, sir. That's what I feel.
You
What
put
I
your
have
finger
tried-
into the loop. I mean, in the
Yes,
hand grip.
I do put it, but that I use just to manipulate. I hold camera with the left hand and right hand rotates the working element as I need it to be. Sometimes it's even right opposite, and so everyone has a
My
different technique of doing it, sir. I personally, I'm probably I don't have that kind of mind, and I like to learn it simple. And I generally try to during my workshops also I try to teach the exact same 3 load technique every time, so that which I have felt it easy to reproduce, and others can also reproduce and
people
do the
are
same.
attending your workshop because of that. I think among the workshops of OLEP, you are the one maximum attended because they are able to replicate, and even Rakesh is telling that, sir, kar sakte hai, after seeing is the secret of the workshop.
Yes, sir. Yes.
He feels that, sir, somehow it is difficult, then it gone.
Sir,
Anyway,
only difficulty is only in cases like the one I showed today. These are
Yeah,
not good cases to be
difficult.
seen.
This
People
is
will
the-
get discouraged to do HOLEP.
Yeah, you should not be discouraged.
Yes.
Next, fifth question. If the laser settings for coagulation and cutting, they say that different.
Yes, sir.
Do you really feel coagulation? Because 90% of the times in thulium fiber laser, same 110 joule or
Yes.
whatever, if you apply a little bit closely, that only coagulates, that only cuts, everything that only. In
Yes.
Humium also I have seen surgeons never use the other setting. Some people say go nearer to it. Some people say go away from it. Some people just change to high frequency and low energy. Any such bleeder at the not at the end, during the surgery, does it really matter during the surgery? At the end, yes.
When we see a spurter as compared to a venous bleeder, like the typical arterial spurter, most of us like to control it. And that is where the aiming beam helps us. I like to point that aiming beam right on it and then coagulate.
What is the energy settings of the aiming beam?
Full, sir, full. Maximum.
Maximum. Okay.
And that only then I will be able to see it during the bleeding.
Yeah.
And then I like to defocus, as you said. I come back a little and try to coagulate. Sometimes that may not work. So only sometimes, and that is when we switch to the other setting. Now, earlier in our older machines, we had to change the setting manually. Now, in the newer machines, we have that setting on the right pedal, on the blue pedal, and we can do it using that. So, not a major
One
issue.
more question. My seventh question. During TURP, large venous sinusoids we see, and when try to coagulate, they become big. They will be opening like a frog mouth, and then the blood will be coming. More you
Yes.
coagulate, more will bleed. If you go away, they will not be seen. But in enucleation, you don't see those sinusoids. Why?
No, sometimes we do see, sir. Sometimes we do see. If there's only some venous ooze, you go there, you try to coagulate, more space will open up just like TURP. But the worst bleeding that you see after opening up of a sinus is when you take out the inner sheet to start morcellation. Then you see red. Then you see real red blood. Because till that time the pressures are high, the bleeding is controlled. And then it is better to take a ball electrode and do some coagulation before proceeding with morcellation. Otherwise, it is because generally we are not taking out scoops of tissue. We are not that deep with laser. We are, even if there is a perforation, it's only a superficial perforation. That is the reason why bigger sinuses don't open up most of the times.
Okay. My eighth question. Whenever you see that entire cavity is without bleeding, you are
Yes.
very happy.
Yes.
The moment you cue marcellator, even with good flow, it looks red. And the moment you put the marcellator inside that marcelloscope, it looks our worst.
Probably
is it
because
of the lack of coagulation?
partially yes, sir, and partially because when you pass the morcellator, everything is through the same channel.
Yeah.
So the flow slightly decreases.
So slightly
Probably
decreases.
because of that.
So if the halfway vision is there, a little bit proceeding, if you do, after some time it stops. But if you coagulate doing again, it's cumbersome, long time.
Not required, sir. One more
Not
thing
required.
is when you are seeing more bleeding, then you are more towards the fossa.
Yeah.
So you need to go little into the bladder
Okay.
and morcellate.
Yeah. Last couple of questions.
Maybe we are staying right at bladder neck, and there we are actually very close to fossa. That's why that ooze is seen.
Yeah. Last couple of questions.
Yes.
What is the worst complication you have seen? A vague question. Vague question.
I think my last session I told you I have once morcellated out the right ureteric orifice. Long way. 10 years.
When you are junior.
Yes, sir.
So-called junior.
I was.
And last, do you think that 22 French is better or 18 French three-way? There are three-way catheters. 18, yes. 20, 22. What will you use routinely?
Sir, I use 20.
20, yellow one.
I do not mind using 18.
Okay.
But my staff is always worried. So they say, sir, 18. So then it's okay, you give 20.
But 18, when you put it, you feel happy in the urethra.
Yes, sir, definitely.
And 22 goes tightly after jelly, you don't feel comfortable.
22 we are not using.
Not using?
Even irrigation, most of our cases we are not giving. No irrigation, no traction for most of cases. This case we use.
When will you remove the catheter?
I remove at 5 days, sir, generally.
5 days?
Yes, I remove after 5 days. That is...
Keep in the hospital, patient?
No, sir. Patient goes home next day. Even same day sometimes. But I remove...
But will they accept to go with catheter?
Yes, sir, they will. If I say I will remove tomorrow or day after, sir, this is on YouTube. I will discuss this personally with you.
And if they are not from Delhi?
Then also, sir, they either they get it removed there or they come back after 5 days.
Okay,
Sometimes we
that's
remove, like in this case,
really accepting this.
sir, I will tell you
I'm
this
still yet to
particular
remove the
patient.
Foley's catheter on before the third day. Some people say next day morning, all Western people say next day morning we will remove. I really feel some mucosa has to grow. I mean,
Sir, you
it,
can remove. I will
you
tell
can
you, sir,
remove,
I'll
there
be
is
very
nothing.
candid. In this particular patient, 350 cc prostate, he was not tolerating the catheter. Catheter was removed on second day. We are flexible regarding this. We have removed next day also, 2 days also, 3 days also, but most of the times, we are keeping for 5 days.
Honest answer I want. In the initial days, now you are 10, 15 years into the field. Maybe first 5 years versus next 5 years, incontinence rate significantly came down.
So first they increased, means initially it was very less because I was very careful. When I mastered the technique, suddenly there was an increase in incontinence rates. Luckily, they were not long-term incontinence, but now my incontinence rates are very less, sir. Only very large prostates, I expect some incontinence. Most of them otherwise are continent. So there are three risk factors for stress incontinence. One is long-standing diabetes, very old patients, and very large prostates. These three category of patients, I always counsel them that you have more chances of stress incontinence. All my whole life patients, I counsel that you have more chances of stress incontinence compared to TORP. Only
Yeah.
when they understand all the risks, then we go ahead with the HOLEP. Of course, we discuss the benefits also.
Last question. Anticholinergics, duloxetine, fluoxetine for any of stress or urge incontinence postoperatively, judicious use is okay. We use.
On demand, sir, as per need, it works. It
But,
works.
but I have seen HOLEP, Tuflep, I mean, for me, Tuflep, after 12 days, very rare to have incontinence. Whereas radical prostatectomy incontinence is more dangerous.
Yes, sir. That's
Obviously.
absolutely true, sir. Absolutely.
Absolutely.
Yes. These
So for anybody, for juniors enucleation, when they are doing, don't keep the fear of too much incontinence in your mind. Do you agree?
Definitely, sir.
You cannot damage the complete sphincter unless you are very bad.
Yes, sir. Everything is benefit versus risks. If the
Yeah.
benefit is more, go for it.
Go for it. Thank you, sir. 177 people have seen. Recently, this is very good one. That means a lot of people are interested. Keep training, and that's great. That in India, ILSS, na? ILSS. Every month, which day you are doing, sir?
It is not fixed, sir.
Fixed, but monthly once you are doing.
Yeah, once a month we do it, sir.
You demonstrate around 2-3 cases minimum, 3-4.
Or 3 to 4, sir. Minimum 3 cases, even 5 sometimes.
How many you can accommodate maximum? 10 or 15?
10, sir. 10, not more than 10.
Not more than 10.
We have kept a limit of 10.
Prior registration is by contacting ILSS?
Yes, sir. They can contact us through Facebook or maybe via Pure also. And then there is a small registration fees to it.
If you have your email address of the hospital, it is better. You can announce because it will be a permanent record.
I will just, how do I announce? Let me just write it on the PPT itself.
Phone number we cannot give on permanent record.
I got it, sir.
This PPT, you give
right
because people will like to, at least people across the country, not only across the country, but outside the country, they like to contact you and come because it's a free training, na? There is no charges.
There is a minimal charge, sir.
Minimal
but
charge.
Just for the seriousness of the program, because many times people used to register and they were never used to turn up.
Yeah,
so
yeah.
2,000 or 3,000 rupees charge is there.
Yeah.
I will
Fine.
just
Very nominal charges.
I will just a second.
Yeah, your personal email or ILSS email if you give.
Yeah, I'm giving my own and ILSS.
In the last slide, usually it will be there, na, sir. Your Twitter, your email address.
That is my email address, sir.
Yeah. Dr. Tanuj Bhatia @ ILSShospitals.com. Dr. Tanuj Bhatia @ ILSShospital.com. You can contact. Tanuj is my close friend. I know he is putting a lot of efforts to teach. That gives pleasure. That gives more learning for us also, for you also. I also do RIRS workshops. I learn a lot. I teach a lot and I learn a lot.
You
This has
always
been,
learn a lot, sir, during this
you
workshop.
always learn, because when you are demonstrating, you
Yes.
cannot afford to do casual mistakes which you do in the theater. I feel that is the greatest service in the present competitive era, where so many people doesn't have the access for this enucleation program in the big corporates also, because bosses won't do it. And even many top class institute don't have access for RIRS and enucleation, but ultimately in private practice, they are bread and butter surgeries. So let's keep training and learning. Go on. Thank you very much, sir. Tanuj sir.
Thank you, sir.
Fantastic.
Thank you for this invitation.
Thank you. Very good. This photo will